Good afternoon, everyone. Thank you for joining our education session again here at Next Step. Just a reminder, if you wouldn't mind just muting your microphones, please, so that we're not getting the feedback. But thank you very much for joining us. Today we're going to talk about our experience of depot buprenorphine, which is a very new thing in opiate replacement therapy, and obviously a very new thing in addiction services, addiction treatment. Firstly, I'd like to acknowledge, show my respect and acknowledge the traditional custodians of the land on which we meet today, and pay my respect to elders past and present. So what's going to happen, I'll present a little bit of some of the pharmacology of the depot buprenorphine that's available. Renee's going to talk a little bit about actually using it in a clinical setting. And then importantly, we've got Derek, who's one of our case managers, to present on the experience that we've had here of managing Buvidal in our clinic. And then we're going to also have Mel, who's going to talk a bit about patient experience, and Thomas, who's our pharmacist, going to talk about depot buprenorphine from the pharmacist's perspective and some of the regulatory requirements. So just to start with, I'll skip over background. I just want to acknowledge Nick Linciris and Adrian Dunlop. A lot of the work that I'm going to present now has been already put together by these two professors from the Eastern States. So just a bit of background. I'm mindful that we have people from a wide range of backgrounds that are dealing with people that come into their treatment services that might have substance use problems. So just a quick background on opiate dependence and how we treat opiate dependence in Australia. So, it's not particularly common, but it is associated with significant physical and social and psychological harms when it is present. Opiate dependence historically has been talked about in terms of heroin use, but increasingly prescribed opiates are much more of a problem in Australia and now represent much more than heroin in terms of overdose deaths, accidental deaths from opiate use. And the strongest evidence for treatment is what is varyingly termed opioid agonist treatment or opioid replacement therapy or opioid substitution therapy. So apologies for all the different terms that are used. But basically, someone who's using opioids every day and has a dependence syndrome either will go through a withdrawal episode and then have some post-withdrawal treatment after that to prevent relapse, which could include something like naltrexone, or they will go directly to either from the withdrawal episode or directly without having a withdrawal episode onto opiate agonist treatment or opiate replacement treatment. Something quickly about post-withdrawal treatment. If someone was to go into a withdrawal episode from opiates and then be followed up through counselling and residential rehabilitation, in particular if it's counselling, or just back into the community, relapse is a significant problem and is associated with quite a number of harms. And that's really why opiate agonist therapy is considered sort of the standard of care now. Some people will say, well, all you do is just replace one opioid for another, and indeed we do, but it's a little bit different, a little bit more complex than that. So we're replacing, the idea being replace a short-acting opioid with a longer-acting one, so people are not having to use the medication as frequently as they need, or the drug. We're replacing something that's illegal with something that's legal and therefore regulated. So we know what's in what we prescribe, whereas, if you're using heroin, you don't really know what's in it. Heroin is injected almost universally in Australia, and there's a lot of issues that you'll probably be aware of around injecting for people's health. The opioids we prescribe for substitution therapy have up until now been oral. Obviously the cost is very, very different. $300 a day for a heroin user is probably conservative, whereas for what we're prescribing for opiate replacement therapy, is much more manageable. What are the objectives of opiate replacement therapy? So obviously to reduce or to cease illicit opiate use or unsanctioned prescribed opiate use, to reduce or cease injecting-related problems, criminal and antisocial behaviour, to help people to engage in treatment, give people the opportunity to engage in treatment of their medical and psychiatric problems or mental health problems, and to address their social comorbidity that all comes with seeking heroin or an illicit opioid, injecting it, recovering, undergoing the effects of the drug and then recovering from the drug and then seeking it again. Doesn't leave a lot of time in people's lives for other things. So how does it work? So up until now, you always will need a doctor, obviously, with special authorisation to be able to prescribe opiate replacement therapy. You need to attend the doctor in some of the treatment services, like Next Step. That will involve seeing a doctor and a case manager or one or the other. In the community, it might be seeing a general practitioner with authorisation to prescribe. To take the medication, you'll need to go to a community pharmacy for what's called supervised dosing. The pharmacist will need to assess the patient for intoxication or whether they're over-sedated before the patient doses. And the pharmacist then has to monitor the administration of the dose to see that the dose is actually taken by the patient and taken correctly. And the patient will have to attend the pharmacy either every day or potentially every second day. So in Australia, up until again now, we've had two preparations, methadone or buprenorphine. So two medications, methadone and buprenorphine, in a few different preparations. I won't go through the difference between them today. But as you can see, we've had methadone for a very long time. Buprenorphine has also been around for 20 years now. And the combination of buprenorphine with naloxone has been around for a little bit less time. Buprenorphine is the subject of today's talk. We're not going to talk about methadone at all. So buprenorphine is has what we call a partial agonist at the opioid receptor of interest, the mu opioid receptor. And the important part about knowing that about that fact is that it's got a low toxicity or low potential for overdose, much lower than methadone and heroin and other full agonists. It's got a very high receptor affinity, so it binds quite tightly and will actually make it difficult for other opioids to be able to bind to the mu opiate receptor if they're available. And I've just talked about how long buprenorphine's been available in Australia for opiate replacement therapy, and obviously today is about a revolution really in our treatments, the available depot formulations of buprenorphine. So why do people look at depot buprenorphine medications? What was the reason behind that? Some of the advantages would be reducing the frequency that patients need to visit pharmacies or ED clinics, to reduce the costs of medications to the patient, improve convenience, obviously, and also improve adherence, so patients don't dose unstably in our terms, or unstable dosing in our terms is people that don't tend to the pharmacy as often as they should. So improve adherence to treatment, and obviously then we have much less concern about people using the medication in a way that's not intended. So what's available are two products of the same medication, buprenorphine. One is called Buvidal, was previously called CAM2038, made by Camurus. Buvidal is available in a number of different doses, either as a weekly injection or a monthly injection. Obviously, 16 milligrams weekly dose just converts to 64 milligrams for a monthly dose. The 8 milligram dose is available weekly only. There's no monthly equivalent of that. And as you can see there, it's in a pre-filled syringe. It must be provided subcutaneously or subcut by a healthcare professional. approved in Australia, New Zealand and Europe, and we inject that into a number of different sites, as I say, subcutaneously. How does it work? There is a particular gel system that has been designed for gradual release of the medications. Essentially, in simple terms that I understand, the fluid is injected into the subcutaneous tissue. When it meets the subcutaneous fluids and tissues, it forms into a gel, which actually can be palpated and actually can be cut out in the first periods of time, but generally over time will degrade naturally and slowly release the buprenorphine at a controlled rate. What's probably important here is to have a look at the graphs on the right-hand side. The blue dotted line on the top graph is Buvidal, a monthly dose. And you can see that the plasma levels are really quite stable for that blue dotted line compared to the grey dotted line. The grey dotted line is if someone's dosing sublingually, so taking the buprenorphine as a sublingual film each day in the pharmacy, as has been done up until now. So it actually does show evidence of providing much more stable levels of buprenorphine in the plasma. The graph on the bottom there is the same thing with some other doses of Buvidal. The second option that's available is Sublocade. I just pointed out that next step in East Perth, we've been provided the Buvidal, so this one, and that's what we've been using. The clinic up at Cambridge Clinic up in West Leederville have been using this particular version in a trial phase. So this is Sublocade. It's manufactured by Indivior. Indivior were the first people to actually manufacture and put onto the market buprenorphine as Suboxone. It's only available in 100 and 300 milligram options. Again, pre-filled syringe. Again, subcut injection by a healthcare provider. The patient doesn't have access to the medication. It needs to be stored in a fridge, and the dosing is basically 300 milligram, 300 milligram, 100 milligram each month. So for a 3-month cycle, you go 300 milligram first injection, 300 milligram second injection, and that will create a steady state plasma level that is sufficient to manage the opioid withdrawal symptoms and cravings. And then you add a 100 milligram dose the next month and continue on that 100 milligram dose into the future for the length of treatment. You'll notice that it takes a while both for Buvidal and for Sublocade to reach steady state. It may be 3 to 5 or even up to 6 doses, which is quite a long time to reach steady state. But that's just part, unfortunately, of how they work. I won't bother with that at the moment. So just briefly, what evidence is there at the moment that this depot version of buprenorphine actually has the effects we hope it has? Well, there's a number of papers that have been published. Firstly, that show that Buvidal and Sublocade both reduce the effects of illicit opioid use or unsanctioned opioid use while they're being provided. They reduce heroin and other opioid use and retain patients in treatment really quite well. And you can see here in a natural conditions open label study, so people knew what they were taking, treatment retention 83% at 24 weeks, which is really very, very high for our patients. And transferring from sublingual or from heroin or prescription opioid use wasn't particularly problematic. I did have some benefits. So benefits we mentioned just briefly earlier on. So patients not needing to go to the pharmacy every day is the key one. That reduces dispensing fees for the patient. They have to pay when they go to the pharmacy every time the pharmacist dispenses something like Suboxone or methadone. Patients report and we'll hear from that later, reduced stigma, less risk of diversion, as I've mentioned, particularly for the therapeutic relationship. We now can lose this constant sort of issue of takeaway doses and who has takeaway doses and who doesn't have takeaway doses. Takeaway doses, for those not initiated, are basically unsupervised opiate replacement therapy doses. And that's constantly a bit of a tug on the therapeutic alliance. Better adherence, as we said, and easier transfer. People travelling for FIFO work are well catered for. Disadvantages, you do lose a little bit of monitoring because the pharmacist is an essential component of opiate replacement therapy. Seeing patients every day or every second day can give us good information about how patients are travelling, so we lose that. And side effects can be problematic for some patients. So I'm just going to hand over now to Renee, and Renee's going to talk a bit about, sorry, I'm going the wrong way. Renee's going to talk about the clinical application of
Thank you, Mike. What I'm going to do in my part of the talk is just try and give you a bit of a snapshot in terms of the process. So just try and take you through what happens when we try and make an assessment of patients going on treatment and we get them on treatment. But this will just be a sort of a glimpse of what we do when we see these patients. I guess one of the first things to keep in mind is that even though we're talking about the same medication, there is buprenorphine in the injection as there is with the sublingual formulation. We found this in the clinic as well. We sort of have to recognize that it potentially does change the way that we do business, or that how we manage our patients. And a lot of it is really due to the fact that opioid substitution treatment, until the point of buprenorphine, has had a lot to do with not just the dosing of the medication, but also the structure that comes along with it. So a patient presents to a pharmacy for dosing every day, but when they come, tied into that as well is regular appointments. So we're used to seeing patients once a week, sometimes more frequently when they start treatment. And then the attendance for appointments where it's not just about scripting, it's about assessing other aspects of their recovery, formulating establishing therapeutic rapport, looking at other comorbidities. So that's all sort of built into treatment. So what we need to keep in mind is that that doesn't get lost in the process of putting someone on Buvidal, because the structure of the appointments does change. And the big difference is that whereas previously the actual treatment itself would happen at a pharmacy, now we're actually factoring in that part of the appointment involves treatment as well, as in the actual administration of the injection. The other thing I guess to keep in mind as well is that because the intervals between doses can be longer, potentially we may not be seeing patients as frequently. And I think we'll get to that part of the issue later in the presentation as well. Now, in terms of the different formulations, Mike mentioned before that there's the weekly and the monthly formulation. In fact, there's not really much research to guide which is more suitable, and we have found certainly here that really it's a choice between each patient and what's more suitable for the individual patient. So there's not much in terms of the research. Some of the things we might want to consider, or we might want to think about, is that we may look at the weekly formulation when we're starting treatment, although this is not a necessity. We may look at the weekly depot for patients who we think might need more frequent monitoring. So in a way, we're actually building into that the need for coming in more frequently so that we can assess them and work on other strategies as well. And we may look at multiple formulation for patients once they've been a bit stable for a little while, or if there's difficulty in terms of attending, particularly for patients who live far away. I just brought up the slide to show you what the application actually looks like. So for those of you who are prescribers of methadone and Suboxone, so in the clinics you'd be aware of, for people who are not familiar, this is just generally what the application form looks like. What I just want to highlight is what's in yellow there. So the difference between the normal applications for authorization is that there are different options on the health department application form. So the health department is actually being informed about the dose of Suboxone that the person is on prior to them going on to treatment, and also when the plan for changing to the injection is. And that's an important thing to be aware of. And the reason for that as well is that it is part of the requirement in general that patients are on the sublingual film for at least 7 days before they transfer to Buvidal. And I will mention some exceptions in a minute. And when you get an authorization from the health department, you will notice in the letter on the right of the screen that it gives you an authorization for the Buvidal, but you also notice that it gives you an authorization, a concurrent authorization for Suboxone that goes for 1 month from the time that the person gets the first injection. And this is really to facilitate the need for additional buprenorphine sublingual if needed, which I'll talk to you a little bit about as well.
Renee, can I just ask that particular application of diazepam, mirtazapine, and baclofen, if there was illicit benzodiazepine use, like is there a maximum level at which you wouldn't give the Buvidal?
Generally not. You still want to look at safe prescribing, safe application, and safe decision making in terms of treatment provision. Or any there's concerns, you would discuss that with the health department.
Yeah. And then the QTC, does it affect that?
The QTC, there has been some concern about QTC with Buvidal just because it's a longer formulation of buprenorphine. As we know, buprenorphine does have a potential for QT prolongation, a lot less than methadone. It's just something to be aware of again. And if there are concerns, then it might warrant doing an ECG prior. But in terms of starting treatment itself, so as I mentioned before, at least 7 days of sublingual buprenorphine before transferring to Buvidal, and that's the TGA recommendation across the board. So we generally would start the injection on the day after the last sublingual dose. And if you look at that little table there, this is how we sort of transfer someone from their dose of buprenorphine to the weekly and the monthly formulation. And when you do that, it's important to look at what the equivalent doses are. But besides that, you can sort of really forget about the numbers, because sometimes patients will ask and get concerned about the fact that 16 milligrams is not really 7 times 8 or 10 milligrams, but so you just try. That's part of talking to them and assuring them that it's really a different formulation that they're talking about. I mentioned before that direct initiation from short-acting opioids is not recommended. So in all situations, you really have to look at a person going on to buprenorphine sublingual before getting on to Buvidal. And in some circumstances, there have been exceptions that have been made, particularly for patients who have come into the detox unit, the inpatient unit. And these have been particularly complex patients where a shorter period of time of being on sublingual buprenorphine is deemed appropriate. And if that is to occur, then generally it's a discussion with the clinical director and a sign-off before that happens. And in terms of what actually happens during the appointment, these basically just give you a bit of an idea of what you want to be looking out for. So for the first appointment, you want to make sure that you've got your health department number. You want to make sure the patient understands what treatment is and and address any concerns they have. Very important to check with the pharmacy, as you do with methadone and Suboxone dosing, as to their dosing history prior to starting. And also really important to let the pharmacy know that the person is changing over. Most pharmacies will be aware of Buvidal, but it also serves as a way of educating them about what will happen and what Buvidal is about as well. And also it makes sense to check on medication and substance use. Now, when a person has had doses, the second, third dose, some of the things you want to be doing are making sure you know when the last dose was given, whether the dose was adequate, so you'll be checking for symptoms of intoxication or withdrawal. Again, a lot of this is quite similar to what you might do with the oral and sublingual forms of treatment. You also want to look at, particularly in the early parts of treatment, the first few doses, whether there were any additional doses that were necessary. So whether these were top-up doses of Buvidal, which I'll talk about in a minute, or Suboxone doses that needed to be given in between. And you would be factoring this in terms of what dose you give the patient. And also, if there were missed doses, then you want to think about how long has been missed, calculating the number of days to see if dose adjustment is necessary, and then making a decision on weekly versus monthly. And a lot of times, this is really in conjunction with the patient in terms of what they are ready for and what their situation is. Well, the site of injection, these the sort of grayed out areas there, the abdomen, the thigh, the arm, and the buttock. Those are the areas that we inject. Again, it's a subcutaneous injection. And the picture at the bottom just basically shows what we tend to do. So we get a good amount of skin. It's a 90-degree perpendicular to the skin, and the injection is given that way. And that's basically what a syringe looks like. After injecting, the things the clinician would need to do, just check to make sure that if there's any immediate adverse effects. What we tend to find is that patients almost inadvertently say that there is a burning sensation that they tend to feel for up to about 10-15 seconds. It's hard to say whether it's related to site. I think it's more patient-related rather than site-related or clinician-related. Make sure the patient is comfortable. There is a dosing administration record which we have sort of used here at Next Step that I'm just going to show you on the next slide. It's just a way of keeping track on the doses that have been given, and also making sure the patient has an alert card. And this is really important because of the length of the duration of action of the medication, to make sure that the patient needs acute sort of pain management, that the clinicians who are providing the treatment are aware. And obviously you arrange appointments for subsequent doses. Going back to what I mentioned before, of making sure that the treatment is part of an overall framework. You want to make sure that patients do have case management, medical, and psychology appointments as well, that it's not just about the injection. This is what an administration record looks like. This is the one that we use here at East Perth. So as you can see, it gives you a one-page, very quick reference as to where the injection was given, so that you can rotate between sites. Otherwise, you can just imagine what a nightmare it would be to try and go through the notes and figure out where the injection was given. It also gives us an idea who provided the injection. Our regulations, the regulations are, if a nurse is giving the injection, then there needs to be a second person to witness that as well. And also, we sort of look at having a brief record of any issues that, if they did come up. And patient alert card, this is what the patient alert card looks like. We encourage a patient to carry this with them in their wallet. And what we've done with our cards here, on the back of that card, we have just a stamp that we put on, which really gives the patient an idea, and whoever they see the GPs about the doses and what doses they've had and when they actually give. So this is what we give to every patient. Now, some of the dosing issues I mentioned before, or may have been mentioned, that there's some flexibility in terms of dosing. In terms of the weekly, we look at 2 days before and after as comfortable periods where you can still give the same dose. In the monthly injection, there's obviously a bit more flexibility. You can go up to 1 week, so between 3 and 5 weeks on either side. 1 week on either side, so between week 3 and 5 weeks of the last injection. Now, when people miss doses, then you try and give them their dose as soon as possible. With missed doses comes the need for reinduction. So if a person has missed generally more than 10 to 14 days of the weekly, or more than 8 weeks of the monthly, then you really should be looking at reinducting. And that really depends on what dose the person is on. And again, there aren't any sort of firm guidelines as to what dose you bring a person down to. I think a lot of it is up to clinical judgment.
Can I ask, with the reinduction, is it oral Suboxone, or do you go weekly injections?
Yes, once a person is on injections and you've had a few injections, there's no problems with going back to weekly or monthly. With supplemental dosing, this is particularly important in the first few doses. Mike mentioned before about the time it takes to get to steady state. So some patients, even though you have matched them to the appropriate dose of Suboxone, they will come in saying that the dose is insufficient. It's seeming to wear off a few days or 1 week before the next dose. So there is the option of giving top-up doses. And whether that's given as an injection, or at least in the first month, the option of giving it sublingually. And a lot of it will be dependent on convenience as well, whether it's over the weekend, whether the person can come in for an injection rather than go to a pharmacy. So also a reminder then is to make sure the pharmacist is aware that with an appropriate script, the patient may present to the pharmacy with an authorized dose for Suboxone if it's needed for top-up, and that's only valid for the first month.
Have we given the actual separate top-up injections of 8 rather than just giving it early?
Yes, we have.
Which is all I'm
on a number of occasions.
Yeah. With the script, do you make it for the whole month for the supplementary film for the pharmacy?
No.
Because it's valid for a month?
In general, we've done that on a case-by-case basis because I think that gives us a bit more control in terms of what's happening.
Okay, because you don't really know when they're going in.
Exactly. So a patient will call us if they say they need it. If we think it's appropriate, we do a script for 2 or 3 days until they come in. Now, the last slide that I have before I hand over to Derek, really is just to go through a few scenarios in terms of how people exit treatment. Obviously, it's planned or unplanned, and some of the scenarios, and I might give one or two examples very briefly of each of them. It might be a planned withdrawal, so a patient has made a plan to actually have the last dose of Buvidal and then come off treatment. We had one patient that I'm familiar of that did this, and we arranged a couple of appointments for her to come back. She came back for one appointment, and about 4 to 8 weeks after her last monthly dose, she mentioned that she was actually going quite okay with minimal withdrawal. So again, it's something that we build up a lot of experience with as we go along. From the point of view of research, there's minimal experience in terms of discontinuation of Buvidal, as to which way you go. Do we go back to sublingual? You just get people to come off the injection. But again, we probably should be talking with evidence-based information. But if from a pharmacological perspective, it might make sense that coming off an injection might be more comfortable because of its long duration of action. Another option might be transferring back to sublingual. So some patients find that the injection do not suit them. One of the reasons that patients have mentioned is that they actually miss the structure of going to a pharmacy daily, and that's slight relief they get from Suboxone. So we have had, I know personally of a couple of patients who had been on the injection for a while. They decided to transfer back because they felt they did better the sublingual. As with other forms of treatment, we get patients to drop out of treatment. Now, transferring to methadone is something that there is very, very limited, if any, experience on. The message there is that needs to be done very cautiously. We're not directly transferring to methadone, but going through, potentially, I guess, going through a sublingual period before transferring to methadone. And the message as well is obviously regular patient review. Just doing all the things that you would normally do when you're helping people to come off treatment, in terms of supporting them and recognizing that there's a potential period of risk and vulnerability. I'll just hand over to Derek now to talk to you about his experience.
The top button. Top button, take you forward.
To move on, yeah. Thanks, Renee. Thanks, Mike. So there has been an impact on the clinic, to be honest with you. The injection is regularly administered by the nursing staff, probably 60 to 70% by the nurses. And when the nurses are doing it, it's in the treatment room. If the doctors are administering it, they could do it in their own room because they have tables and that to do it on. Injection reactions are uncommon, like Renee said. Clients self-report a bit of pain and increased swelling, possibly 10 to 15% of the clients. We have over 80 clients into the clinic just now. Like Renee mentioned, there is pain and burning for probably about 15 to 20 seconds. It seems to be at the end of the injection and then about 20 minutes afterwards as well. Some clients will report it similar to a bee sting or a green ant sting. So it seems to be pretty painful, but again, not all clients experience that as well. As highlighted before, we use various sites to inject. Again, the clients may decide on if they want a particular site, and it may change from clinic appointment. Some sites are more painful than others reported. I suppose we have to consider the client adamant they just want one site used. Then we have to have a discussion with them, and if that's what their choice is, then that's a consent issue. And especially when they're on monthly, I suppose it's not really that pressing if we use the same site every 4 weeks, to be honest with you. Initially, there was report of some droplet leakage at the end of the injection. Not that common, but to be honest, after slowing down the injection, that seems to have minimised, although on occasions you still get that at the end of the injection as well. Administration, so like I said, it's been impacted by the introduction of Buvidal, especially when we transferred clients last September onto it, and the frequency of the appointments were initially weekly, which did impact on clients, on staff's time and the administration of the injection. We had clients who were on stable dosing of Suboxone. They used to come 3 monthly. So a case manager for 30 minutes and a doctor for 30 minutes as well. Until they got to an optimum stable dose of the Buvidal, then they may have been seen 3 or 4 times for weekly injections and then transferred onto monthly injections. So the impact is, rather than 1 hour appointment every 3 months, it could have been up to 3-hour appointment over the 3-month period. And if you times that by 80, then that's the equivalent of 240 working hours. So again, that certainly impacted on the client as well. Unstable clients may have been seen like 2 to 4 weekly, and again, until they were on an optimum dose of the Buvidal, then they might have been reviewed weekly as well, rather than every 2 to 4 weeks. Again, impacting on clients, impacting on the clinic's time, and also staff involved in that as well. We have to be mindful, as Renee mentioned, it's like it's not just the injection, it's not just 15 minutes for the injection. At the end of the day, clients need to be reviewed, make sure the dose is suitable, do the urine drug screens, make sure the injection sites are stable, any new medications, mental and physical health, as well as their social situation as well, because with our cohort of clients, that could change from appointment to appointment as well. We have mentioned the context of a depot administration clinic. I think other sites have, Joondalup especially has been progressing with that as well, but we've not progressed to that at this stage. Case management model of care, like Nick said, to conduct case management model. I think when it first started, the ongoing challenges of reviewing own clients were challenging, especially when they were commenced on weekly injections. So a number of other case managers and even involving like duty clinicians had to be involved, so the clients had their weekly Buvidal. I think that's kind of stabilised when the clients go into monthly injections, but again, it really depended on staff availability. Ongoing challenge is back-to-back case manager medical appointments as well, especially if the appointments have been increased to weekly or monthly when clients were on 3 monthly or monthly previously to that as well. Impacts on the nurses especially as well, because like Renee said, 1 doctor can administer the Buvidal, but 2 nurses have to check and have to be there while the injection is administered as well, which can be time consuming. And on occasions, again, not as frequently as it was, can be challenging to locate a second person as well. It certainly helped. Now the medical staff are completing the prescription with 2 repeats at one time, so that does save trying to locate a doctor, so they have to complete the prescription. Like I said, the Buvidal injection has been spoken about. We could probably be looking at as well for effective case management, rather than the allocated 30 minutes. The injection to facilitate that and to administer can take an additional 15 minutes. So consideration may be looked at a 45-minute assessment if we want to continue with the case management model. And also to be mindful of, although most clients have been attending for their injection within the allocated period, we have to be mindful for weekly injections. We can give it between 5 to 9 days, on monthly 21 to 35 days as well. But we do allocate the appointments after injecting, so if the clients can't manage on that day, Then again, the challenge will be finding appropriate time and finding appropriate staff to administer the medication. I'll hand over to Thomas now.
Mel.
Do you want me to?
Yes, please.
Sorry, Mel.
Mel, can you come?
I'm going to move.
Yeah, sure. Yeah. Mel's just going to talk briefly about a survey that he's done of patient experience with the depot, with the Buvidal depot.
I'm sorry I don't have any slides, and I'll be as brief as I can. So this is more a survey of people's subjective experience on the Buvidal here, and there have been 31 respondents so far, and there's not really anything that is dissonant with what we talked about so far. So I asked how many people had been on Suboxone or had come onto Suboxone just to go onto the Buvidal, and 80% of our sample were already on Suboxone. The side effects that we'd said were pain in 80% of people, and that was at most moderate and resolved after 15 minutes. About half the cohort reported redness and swelling in the week after their injection. The side effects that people described were mostly to do with Buvidal, really. So there was sedation in the 6 to 12 hours after the depot, and a third of the respondents reported end-of-dose symptoms. So, and they're more or less attenuated withdrawal symptoms when you ask about them in the last 2 days of the weekly span or the last week of the monthly span. So I was a little surprised that that was as common in this cohort and it didn't seem to be reflected in the literature so much. In terms of whether people felt more stable on the depot, half the sample said their stability was increased with regard to experiencing withdrawal symptoms. 40% said that their mood was improved, and of the people that had chronic pain, 40% said the depot was better at controlling their pain. Most said that it wasn't any different. I asked people whether they tried using illicit drugs whilst on the depot, because blockade is an important part of our treatment. And of the 50% that admitted to using illicits, a third said that the depot was better at blocking their illicit use than the Suboxone film. Most said it didn't make any difference. So 90%, in keeping with the literature, said that they preferred the depot over their Suboxone, and 75% said they greatly preferred it. And mostly it was for the reasons that we'd suggested, cost and not having to attend the pharmacy. But a recurrent theme was the reduction in stigma that we've talked about, that people could maintain anonymity and there was a break in the cycle of using. And there were a couple that said that they preferred the film because it reminded them that they were on a treatment and they couldn't use. And in terms of improvements to the treatment, making it last longer so they didn't have the withdrawal effects, and making it more available, suggestions of GPs being able to prescribe it.
Thank you very much, Mel. We're just running close to time, but Thomas, we asked Thomas if he could just present a little bit on some of the regulatory issues and pharmacist experience with Buvidal. Just have that here, Thomas.
So I'll be very quick on this, and this is sort of just my perspective as a pharmacist, having been involved with the program for the last 6 months. So I think with Depot-Boo, this will create a shift in the opioid pharmacotherapy model of care for pharmacies, because obviously patients don't need to go to the pharmacy to dose daily anymore. And for the majority of people, this will be really good, as Mike's already talked about all the advantages, for example, the greater convenience. And we particularly saw this play out during the pandemic, because patients didn't have to attend to the pharmacy daily, and so they could social distance themselves from the community. All the other ones, the stigma we've talked about, and there is like an advantage that we don't often think about, is that methadone tastes really bad, and not having to take that every single day will actually help to improve your mood. You know, you don't have to think about swallowing a really bitter liquid. So, although in our experience, some people may prefer the daily routine and support from going to the pharmacy, and in our experience, it's about 5 to 10% of people would prefer to stick on Suboxone. Is that? Okay. But I believe that with buprenorphine, the relationship between the pharmacy and the GP or the clinic will become even more important, and I'll try to explain why. So, firstly, all those involved in opioid pharmacotherapy in WA, from the doctors to the pharmacies to the clinics to the patients, all need to apply for approval from the Department of Health. And in WA, the Department of Health work together with CPOP to manage the opioid pharmacotherapy program. And we're very lucky in WA because both these departments run a very organised and a very safe program. The other states have different procedures and processes, and I won't go through all that. But this requirement requires a pharmacist and a doctor to be involved before a patient gets opioid pharmacotherapy. And this creates accountability because things can go wrong if it's just one person ordering, supplying, recording and reporting a drug of dependence. So once everyone is approved, the doctor writes a prescription for Depo-Boot. The approved pharmacy receives the prescription, dispenses it and delivers it straight to the approved clinic for administration. At no point does the patient need to handle the medication. And I think this sort of delivery arrangement can be worked out between the pharmacist and the GP clinic. It will work best if the medical centre is right next to the pharmacy. It lowers the delivery costs, and the pharmacy sort of needs to be reimbursed for everything that they do. For example, they need to order it, record it, report it, and also to manage the program as a whole. The feedback that we're getting is that it probably costs around $30 to $50 per month for the Depo-Boot, which is considerably cheaper than the $150 to $200 per month for daily Suboxone or methadone. Okay. So with Depo-Boot, pharmacies can gear towards more providing support to the clinic and the doctor as opposed to the patient. So for example, the pharmacy can ensure that there's sufficient stock and letting the clinic know that if there are any issues that may affect the supply. And then if there are supply issues, then you can work together with the doctor to find an alternative treatment. The pharmacy can also supply miscellaneous items that the doctor or the surgery would need in order to gain approval from the Department of Health, such as like Schedule 8 registers and things like that. And of course, we can provide the usual pharmacological advice, which is our sort of bread and butter. So we can provide advice on pharmacokinetics and interactions. And I'll just go through 2 common questions that I have got in the last 6 months. So the first question is, when is it possible to give an opioid-based analgesic for someone on Depo-Boot? And the short answer is not really sure. Because with buprenorphine, Walsh did a study and said that you need plasma levels of 1.25 nanograms per mil to achieve effective mu receptor blockade. And Camurus, which is the manufacturer, says that at 2 months from the last dose of 128 milligrams Buvidal, the boot levels are still at 1 nanograms per mil. And of course, then there's also pharmacokinetic differences between individuals. So we're not actually really sure, so we refer to the National Guidelines for Medication-Assisted Treatment for Opioid Dependence. I won't go through this because if there are pain specialists out there, this is your bread and butter anyway. But essentially, we just recommend using higher doses of traditional opioids, using a mu opioid receptor superagonist, or going through the non-opioid analgesic approach like ketamine. And I put the last sort of bit in red because if a pharmacist is working in a hospital, or even a doctor, if a patient goes to the hospital and they're on an opioid program, the pharmacist and the doctor need to confirm the patient's last dose of that opioid, and usually you would call the pharmacy, But now you need to, if the patient is on Depo-Boop, you need to call the clinic because the clinic has a record of the last dose administered, not the pharmacy. And the second question is that, or the second issue is that a lot of patients tend to say their first dose, not a lot, but some patients tend to say their first dose doesn't provide sufficient craving control. And that's certainly reflected in Mel's survey, about 1/3, I think you mentioned Mel. So then the pharmacist can go look back at the pharmacokinetic properties, and it takes about 3 to 4 doses to achieve steady state, whether you're on weekly or monthly depot injections. So we can sort of counsel the patient and let the doctor know that, look, it may just take 3 to 4 doses before you get sufficient control. So all in all, in summary, I think with Depo-Boop, even though the pharmacy will see the patient less, the relationship between the pharmacies and the doctors will become really important, and the working relationship will be improved.
Thank you very much, Thomas. Thank you very much for everyone for listening. I'm sorry we went over time there. Just want to ask if, firstly, thank Derek and Renee and Mel and Thomas for helping us put this together today, and just ask if there's any questions from anyone listening in.
I have a question. The reverse with naloxone to the same dose, but need extra dose for naloxone, does it depend on the Buvidal dose that you're on?
Good question.
You're probably unlikely to need naloxone if you're on this.
Yeah, but only if you use additional opioid on top of the Buvidal.
You're using it for the additional opioids, so I guess that'd be my guess.
Yeah, okay.
You're using it for that, so it'll be the same.
Yeah.
But this, of course, would block a lot of opioid activity at the receptor.
It does, but I mean, you can still, polysubstance overdose, you can still...
Polysubstance, but then that wouldn't, naloxone wouldn't have too much of an effect there. Be interesting.
I think the previous concerns about, when there were concerns rarely about buprenorphine overdose in sublingual, was when people had access to the film and they took huge amounts of the film. And even then it was very uncommon.
64 milligrams.
Yeah, but we're not going to see that here, hopefully, because hopefully if you adhere to the dosing recommendations, then you're probably unlikely to get an overdose situation. But it's not impossible, I guess.
No.
I take it we haven't heard of any yet of overdose in our patients on Depo?
No.
Because that'll be an interesting thing if that happens.
I was going to say that survey experience was consistent with what you said, in that the people who had a relationship with their pharmacist said they continued to go to the pharmacist to buy things or get their medications, their regular medications, and that the pharmacists were very supportive of their patients progressing onto Depo, and said, come back and tell us how it's gone. So it wasn't that lost relationship. It didn't happen as we thought it might.
I wasn't sure if it was raised or not in the talk. The number of people who do get top-ups, is that 1 in 5, 1 in 10?
Mine would have been about 30%.
And they wanted a top-up or got a top-up?
Well, wanted one. So some people wrote it out, but a lot came in early. That's what most people did. They came in before their span was up to get an earlier injection.
And that's what we do, an early, because I think someone might have asked that. Do we normally get an early injection or a sublingual?
Renee was saying that we usually give the sublingual at pharmacy, and we have also given a number of people early injections or top-up injections, 8 milligrams. But we haven't got a formal or any data collection process in place to be able to answer some of those questions.
I think that would depend on the situation. Like if they're calling on the weekend, you give Suboxone at the local pharmacy. If they can get in here early, then we'll give an early dose. Or if they can't get in here early and they can't make it during the next injection, then we might give a top up for the 8 milligram injection.
If you have someone on 4 daily and they want to go on to the monthly, what would you do? Would you put them on an 8 weekly and then put them on the monthly, or would you go straight on to the lowest monthly? This is a question from Brett.
Yeah, we had exactly that situation with one of my patients, one of our patients, who was only on, was on 4 milligrams daily, been on that for a very, very long time.
Yes.
Wanted to go on to Buvidal, so we had him on weekly for quite a while, for as long as he could tolerate that. And then we had a discussion about, look, if you do go to monthly, it does mean increasing your opioid tolerance, which means you go up. So we got him up to the next weekly dose.
Right.
So he went from 8 to 16.
Right.
And then he transferred over. So now he's on 64 of that, which is the lowest monthly dose, and didn't notice any increase in sedation when he went up to the higher weekly, or when he transferred over, and is a lot happier.
So we're not confident enough to risk putting him straight onto the lowest monthly from 4 a day.
I haven't, because I was very sure that he was not using more, and so his opioid tolerance would have been a lot less than someone who was using heroin.
And my one patient has been very similar, who was on 2 and was quite sedated on the 8.
Yeah.
Having said that, Mel, this slide, I think, is showing when you look at Sublocade, because they've only got their 2. Please tell me if anyone knows better than this, but from what I understand, they only have their 2 doses, so they have their 100 milligram dose and their 300 milligram dose. And so that's steady state plasma levels. And so if you look at if you've got someone, sorry Tom, you've got someone down here on sublingual bid, say 4 milligrams, and so their steady state, I don't know, maybe sitting down here, they still will start them on this regime, and it seems to me one size fits all.
For Sublocade?
Yeah, for Sublocade, and it doesn't seem to have had problems. I mean, it's obviously been through the research process. So it's an interesting thing that we have. Buvidal has the range of doses. Sublocade has the sort of one size fits all. The only variation I'm aware of is the 300, and then either 100 or continue with 300. So,
one issue that came up this week was a person on Suboxone who was on 4 milligrams, wanted to go on to Sublocade, and there's no equivalent to 4, and the permission wasn't granted, pending that person actually increasing their sublingual, basically doubling it to 8. So, and what I'd love to know is if anybody else around Australia is putting people on less than 8 on Sublocade, and whether that in effect makes any real difference. But then you had a patient who felt
sedated on small Buvidal, yes, on the lowest Buvidal.
And
definitely.
Monthly, I think that would be a bit of a concern.
I think there would be experience though, because John Edwards, there's the man in Queensland, the doctor in Queensland that's using Sublocade that John Edwards would know of.
Tim, yes.
There would be, I think, experience in that.
I've got a question. Do we know the utility of Buvidal for analgesia? Is there any, obviously using Northstone patches?
As a treatment?
As a treatment. I mean, or in chronic pain patients that we've started on Buvidal, do they get any relief?
Most of the patients in the survey, of the half of those 31 that said they had chronic pain, I think, was it a third, that said it was better? Right. And then 50% thought it was equivalent to Suboxone film. This is comparing it to film. So it's as equivalent as the film was for them, and there were only a small number that felt they were worse off. Interestingly, the people that complained about the depot not being as good still opted to stay on it because of the cost convenience.
I just wondered if they developed it for chronic pain.
No,
actually.
No,
they won't.
They would have loved it. They would love to get their hands on Suboxone as well as a pain management tool, but it's not registered for that, so that can't happen at this stage for you, Marcus.
Thanks, everyone.
Great, thank you. Really interesting.
Thanks, guys.
Thanks.
Thank you.
Thank you.